All right, guys, welcome back to our channel. This is going to be an interesting case. It was a gentleman in his 40s who had a really terribly infected tooth, and he really wanted an implant. The tooth needed to come out. He really wanted an implant, and he had a huge bone defect. So I want to walk you through how we do those defect. This is what you call a 3-wall defect, and hopefully it can explain some of the things we do and why we do it. So let's get started. So here we are. Again, this is a 40-year-old gentleman. He went to see his dentist. He was having pain in the area of the lower left first molar. I want you to notice here, right in this area, he was right in this area. There's a tooth with a root canal. These white lines, these are root canals. And I want you to notice all this darkness around this root. And there was a lot of darkness in this area here. The dentist, thought, well, this tooth is not fixable. It needs to come out. And what we did is we brought the gentleman back to our office. We took a CT scan. This is a scanner that's available in our office. And one thing that jumps at me right away is you can see the roots in here, but then you can see this big bony defect. The roots are literally coming through. So this gentleman from chronic inflammation lost all this bone in this area. And the danger of leaving these teeth in the jawbone and not taking them out is really, a lot of times they start losing more and more and more bone, and then you end up affecting the adjacent teeth. Then a lot of times the bone loss progresses, and then you start losing bone around this tooth and then around the tooth behind it. And as a matter of fact, this gentleman actually lost a lot of bone on the backside of this tooth, and the roots of the tooth behind it were exposed. So I'll show you what that looks like in a minute. And I don't have initial pictures, but I hope you can appreciate the size of this bony defect. It's pretty big. As a matter of fact, once you take the tooth out and you clean up all this infected tissue, you really can notice there's really not much bone left here. And you simply cannot put an implant here. There's really no way the bone's going to heal all the way. So for example, if we put a little dental implant right here, like this, we need the native bone cells to grow into this defect around the implant. And this is going to be in the way. And there's no way we can grow bone all the way around it. So really we had to build the bone first. In this situation, we had to build the bone first, and then hopefully we get enough bone growth. That's number two. These are very, very tough defects to rebuild, and I'll show you how we did that and some of the reasoning behind it. But they're tough defects to rebuild. And also what's really tough is this area. You can see the root of this tooth here. It is exposed. It is extremely difficult to rebuild bone around these roots. So it's very, very important that when we do this procedure that the surgeon cleans the root surface so there's just root exposed, and so the bone can bond to this area. And that's kind of what we did. We actually used, this is human cadaver bone. We filled the defect with human cadaver bone, and it's soaked in this patient's blood. And then we added a substance called Emdogain. It is made by a company named Straumann, and Emdogain basically helps the bone rebuild around roots of teeth. And on top of this, we put a membrane. And this is what the membrane looks like. This is cross-linked collagen. This is the membrane. And this is what you call guided bone regeneration. And the reason why we put this membrane is we use this membrane as a barrier. So the bone, the soft tissue cells, the cells from the tissue that are here, won't grow into the graft. So this acts like a barrier. And the reason why we need this barrier is because soft tissue cells heal extremely, extremely quickly, and soft tissue cells will grow into the graft before, the bone cells from the native bone grow into the graft. And so we need this membrane to stop soft tissue cells from growing to the graft, because if you just get soft tissue cells growing into the graft, you're really not going to get good solid bone. And then we literally suture everything up. We suture everything up, and this is what it looks like from the top. It is extremely important in this scenario, if you have a really well-skilled surgeon, is that we get what we call primary closure, meaning this defect used to be this big. And now what we did is we pulled the soft tissue from the cheek and closed this primarily. So this and this meet. There's a little defect here, but that closed up pretty nicely. And then we kind of give this area to heal. The minimum healing time on something like this, especially a defect this big, is 6 months. It really takes an extremely long time for the bone cells to grow into this grafted bone, because this is the bone that we use is human cadaver bone. It doesn't have any tissue in it, it doesn't have any cells. So your bone cells from the neighboring bone are going to grow into it slowly, very, very slowly, as a matter of fact. And it takes 6 months for these bone cells to make native bone. In this case, actually, it worked out extremely well. We were able to grow good bone in this area. But you know, we definitely waited. Actually, sometimes waiting more than 6 months is better, because you come back. We got this gentleman back 6 months later. This is what the area looks like on a 2-dimensional x-ray. We have very nice bone level here. This area, and I'll show you the 3 dimensions. We were able to grow the bone, but again, the bone didn't come from the grafted bone. The bone cells grew from the native bone into the graft. This is why it takes so long. I want you to notice here in this area, there is no darkness around this root, meaning we actually have bone growing around the root of this tooth. This is pretty difficult to do if you don't have the right materials. So that's why sometimes it's important that if you have a situation like this, that you go to a surgeon who really understands biology, understands how to grow bone around these roots. Here's a cross section of this area, and we were able to get a lot of bone. As you can see, this is the facial aspect, or the cheek aspect, and the bone in this area is very nice. It looks great. And we were able to put a dental implant in there, and I'll show you pictures what that looks like. This is at the time of the second surgery when we were placing the implant. As you can see, you know, we did pull some of the cheek this way, and it closed it over. But a lot of times when we uncover this implant, we pull this back, and so you don't have this tension here. So that's not a big deal. And as you can tell, it looked initially really, really swollen after surgery, but it looks pretty good now. There's not much swelling there. That's pretty typical, what you see, you know, especially if you give it a long healing time 6 months later. Then it's another view. Bone growth looks good. And this is the dental implant placement. And I want you to notice right in here, very nice. We had literally no bone in here, and we had no bone in this area. And you can see we have very, very good bone growth. This is very nice result. Very, very nice. And then what we do, we put a dental implant. This part right here is the implant carrier. This part right here is the implant carrier, and the implant, and these are actually bone level implants, so meaning the platform of the implant is here, and then the body of the implant is down here. It's inside the bone. And we actually bury everything in this scenario. We bury the implant, and we let it heal for typically 3 or 4 months. And these implants undergo a process called osseointegration, meaning this bone cells will actually integrate to the titanium here and here. But this does take a long time, so you really can't load these implants for at least 4 months. So I typically like to bury them, so the biology is doing its thing, the bone cells are healing to the implant, and then we expose it. And this mount comes off, like I said, and that's what it looks like. Again, just to show you, this is the implant platform. These are titanium implants, and sometimes you get bone growing into this hole, so we actually cover this with a cover screw. And that's what the cover screw looks like. Seals off the hole, we suture everything up, and that's what the area looks like afterwards. And that's really the end of the case. We ended up restoring this with his general dentist. We typically, after 3 months, we'll take out the cover screw and we'll put a tall healing abutment or a healing cap sticking out of the gum, and then so the dentist has access to the implant there. I don't have pictures of this, but if you look at my other implant tutorial, you'll see a step-by-step of how we restore these implants. But really, this is more about growing bone and guided bone regeneration, and why we use membranes, and what to do when you have a 3-walled defect. I'll go back and I'll talk about 3-wall here in a second. Going back to the initial surgery picture, this is probably what you would call a 3 or a 2-wall defect, meaning the native bone, there's a wall of bone here, there's a wall of bone on this side, but then it's missing here, and it's somewhat missing here. So a 2 or 3-wall defect are very, very hard to reconstruct, because you really have very little bone from the native bone, very little bone cells here. There's not much, so very thin, and so this is a very tough area to reconstruct. Sometimes if you have absolutely no, if this was missing here, then this would be even more difficult, because now you're relying on the bone cells to travel from here and all the way back here, and the longer these bone cells have to travel and rebuild the bone, the less successful you are. So you really need somebody that knows what they're doing and understanding biology. But that's kind of what you call a 3-wall defect, and these can be very successfully grafted if you do a proper guided bone regeneration, and also closing the tissue. So meaning the tissue from the cheek here has to meet the lingual part, and that's also very important. So I hope you guys got to learn something today, and if you have any questions or issues, please make some comments. Would love to hear from you. Let me know what you want me to talk about, what you want to hear, and you guys have a good day.